Good afternoon, everyone. Welcome to today's Big Ideas lecture hosted by the Institute for Education Research at UHN. I'm Ann Russell. I'm the Director of Applied Research at TIER, and it is my distinct pleasure and honor to introduce today's keynote speaker, Dr. Catherine Nicol. A little bit about Catherine. Catherine is the inaugural chair for TIER's advisory committee, and she's the past lead for practice-based research and innovation at both UHN and Sunnybrook hospitals. Today, Catherine leads a rapidly growing research portfolio at VHA Home Healthcare, where she is the Vice President of Quality, Best Practice, Research and Education, as well as the Chief Nursing Executive. Dr. Nicol is also Assistant Professor at the Dalla School of Public Health at the University of Toronto, where she supervises graduate students and conducts research in the occupational health and safety of health professionals. Catherine is also lead for VHA's Incident Command Team and tasked with coordinating VHA's crisis response, and was a member representing the home care sector of the Ontario Health Toronto Region Pandemic Planning and Preparedness Table. Finally, Dr. Nicol is also an investigator with the Centre for Research Expertise in Occupational Disease. The title of Catherine's talk today is Home Sweet Safe Home. What did we find out about Ontario's home care sector from navigating the 2020 COVID-19 pandemic? Please join me in giving a warm welcome, and it is with much gratitude, Catherine, and appreciation. We look forward to hearing your talk and learning from you about the experience at VHA and in the home care sector during COVID. Over to you, Catherine.
Okay, thank you, Anne, and good afternoon, everyone. It's really a pleasure to be here today to share the experiences of the home care sector in response to the COVID-19 pandemic, and I really hope that Michener and the education research community finds this information helpful when designing educational programs that will best prepare students to work in all sectors of our health system and to fully understand a patient's journey when navigating these very different sectors. So Anne shared a little bit about me. So let me tell you a little bit about my organization, because that is where my stories and my experience is based. So VHA Home Healthcare, we're a medium-sized home care agency. We have about 3,000 staff, and we provide nursing, personal support, and rehab services to over 110,000 unique clients every year. And this works out to about 1 million units of service. Our organization is very Ontario-centric, and most of our business is in the GTA, but we do have 2 regional rehab offices, one in London and one in Ottawa. And we also have a very unique community supports line of business that VHA supports through its charitable resources, and with the support of several important funding partners. And those programs are focused on vulnerable populations with a focus on keeping people housed and avoiding eviction. And they include parent relief, extreme cleaning, and hoarding support. So it's a very interesting and diverse organization to work in. VHA has been around for a long time, since 1925, so we're coming up on our 100th birthday. And Anne has already shared the role I play at that organization, which is essentially leading the clinical and quality side of the house. And most relevant to today's talk is that I was the lead, still am the lead as our pandemic lives on, of the crisis response team at the organization. So just going to ask Matt to move us along to slide 2. Thank you. So today I'm going to focus the next 40 minutes or so on 4 key areas. I want to share with you the uniquity of the home care sector and describe that for you, because it is quite a unique sector. I'm going to then move on to our early response, using again VHA as my source of information, and just share some of the resourcefulness, the innovation, and the collaboration that was experienced across the sector. I'm then going to focus in on 3 key successes. There's been many. Many of us have had lots of successes, and there's been silver linings for sure. I'm going to focus on 3 of them. And then I'm going to finish up with leadership learnings and some personal reflections. and we'll keep my eye on the time to make sure we have time for questions. So just moving along to slide 3. Thank you. So first, let me share some facts about Ontario's home care sector. And actually, before I do, maybe I need to come clean. So while I have worked in the provincial healthcare system since the very beginning of my career as a nurse, the majority of my time has been spent in the acute healthcare sector. And I certainly understand hospitals. They're a great place to work. They're well funded, staff are well paid, and there's ample opportunities for learning, professional development, and team-based work. And client and family care is exceptional. I moved over to the home care sector in 2016 to broaden my experience, both from a leadership perspective and a sector perspective, because it was very clear to me, even before 2016, that the future of a sustainable public health system in Ontario truly is investing in and elevating home-based care. It's cost efficient, it's the bottom line, but it's also where people want to be. So I just want you to know that my home care experience is really 4 years old, but that 4 years has been packed, and especially the last year, I know it's been packed for many of us, but it's certainly been packed full of learning for me. So some facts about Ontario's home care sector. So home care was established in 1970 as a critical component of Ontario's health system. Unlike long-term care, which is a co-pay model, where home care is tagged as fully publicly funded, so similar to what hospital care would be. Last year, under local health integrated network funded home care contracts, that's how the business is organized, more than 730,000 patients were served and over 53 million visits were made, all within a budget of $1.8 billion. Certainly change is afoot right now with the anticipation that funding is going to be moved from the LHINs over to Ontario Health Teams, and it's going to be interesting to track that, in the near future and see how it progresses. There's approximately 100,000 frontline home care workers in Ontario, many of which are unionized under some of our most common unions, SEIU, ONA, CUPE, and OPSEU, just to name a few. And while home care workers certainly include nurses and rehab therapists like hospitals, the vast majority of home care providers are personal support workers. And this is a very unique occupational group. It's unregulated, primary female, which is similar to other healthcare occupations, and overrepresented by racialized people and/or immigrants to Canada. The entry to practice education in Ontario for PSWs has a standard curriculum, but it includes an array of training programs offered in public, private, and vocational colleges, school boards, and online. So it is a fairly complex educational landscape for this group. PSW work is also considered precarious. This is for two main reasons. One is due to low wages. So PSWs in Ontario are paid between $16.50 an hour to $20, and that's not including the current pandemic top-ups that group is temporarily receiving. And it also has unstable and unpredictable work hours. And this is due to the current pay-by-unit compensation model that's used in the province. Home care services are provided 24 hours a day, 365 days a year. And if we were to try and break up our patient population, or we call it our client population, it's approximately 60% seniors, 20% adults, 15% children, and 5% palliative care. But that palliative care number is certainly growing. And the majority of services are provided through visits, and those visits can be 30 minutes to an hour, sometimes up to 2 hours. And there are some shift-based services for short-term or longer-term high acuity or chronic care clients, and travel is often included within the hourly wage. So even though services are delivered primarily in people's homes, there are a number of other settings where home care is provided. So congregate living settings like homeless shelters, workplaces, schools, ambulatory care clinics, step-down transition units, and retirement homes and long-term care settings. So it is a diverse context for our home care workers. One of the most interesting things about home care work is, unlike institution-based healthcare, workers in the home care system work alone, and they work without the support of their manager, their peers, or the broad interprofessional team. And I can tell you, even though I have never been a frontline home care worker, I've shadowed many home care workers in my four plus years at BHA, and I've witnessed the incredible care that they provide autonomously and independently. I've watched an occupational therapist conduct an urgent suicide risk assessment on an elderly client, where the reason that they were actually visiting was to do a mobility device assessment and measurements. I watched a palliative nurse activate what we call a symptom response kit, which is essentially a kit comprised of a myriad of significant medications for a variety of serious palliative symptom management reasons, and a raft of associated medical orders to choose from. While at the same time providing comfort and guidance to a grieving husband and grieving teenage children. And I've watched a PSW use music and singing to skillfully navigate a client experiencing aggressive, responsive behaviors due to sundowning. And I have to tell you that doing this kind of work with a team around you is hard enough. Doing this work on your own is truly something to respect and admire. So what happened when COVID hit the home care sector? Now you know a little bit about the home care sector. You know what happened when COVID hit the home care sector in early 2020. So first and foremost, it's important to understand that the focus was on hospitals, getting the equipment and health human resources into place to care for the sickest COVID patients. And while this makes complete sense, it is important to understand and to share that in the first weeks and months of the pandemic, there was little to no support for the home care sector. Our workers were absolutely deemed to be essential, and our doors needed to remain open, especially because if we didn't do that, our patients would have flooded the hospitals, which would only have escalated the crisis. But we could not source equipment and supplies. Guidelines specific to our sector were not first in the queue to be developed. And school and daycare closures and fear and anxiety markedly reduced our already strained workforce. So it was a really rough start. Thankfully, although our finance team would not agree with the choice of that term, many clients canceled or put their services on hold due to fear, and referrals through the health system stopped. So our shrinking workforce met the needs of our shrinking volume, which was, that's why I say I was a bit thankful, because I'm not sure what we would have done if our workforce had shrunk drastically and our volumes had stayed the same or had grown at that time. The interesting thing about those holds and cancellations, though, is that the need for care for those clients did not go away. What happened to that? Who stepped in? And it was picked up by unpaid caregivers, families and friends, some of who had new work at home arrangements, like some of us do, or whose work had slowed down or had temporarily been put on hold or had ended. And while we heard that this was manageable at the beginning, it was certainly not a sustainable solution, and it quickly became overwhelming. And I can't tell you how many stories I heard and were shared with me that were absolutely ethically devastating. I can't imagine what the long-term impact will be on the mental health and burnout of this really important group. So just moving along then to slide number 4. Thank you. So how did home care agencies cope in the first weeks and months of the pandemic? The response is the sector was resourceful, innovative, and worked together. And I'm going to give you some key examples of resourceful and innovative and working together. But I think right now I'd just like to talk a little bit about this notion of collaboration in our sector. The home care sector is traditionally competitive. The way it's structured is that agencies compete against each other for very large contracts. And as such, relationships are competitive. The landscape is collegial, and we're getting more collaborative as integration efforts advance, but relationships are still best described as competitive. The pandemic, though, changed this and resulted in some highly successful collaborations one of which I'll share with you. So let's start with resourceful. And I have a bit of a background in infection prevention and control, and in studying the use of personal protective equipment during SARS in hospitals. So my examples focus on personal protective equipment. But I think what's important to understand is that in the early days, PPE was one of the hottest topics across every sector. Home care is not a sector that has used PPE in a meaningful way beyond gloves in the past. In addition to gloves, personal support workers may have used plastic aprons when bathing or changing clients, but they very rarely would have used fluid-resistant gowns or any kind of facial protective equipment like surgical masks, N95 respirators, or eye protection or face shields. Nurses might have used facial protective equipment a little more often, but still not that frequently. Home care companies certainly had relationships with suppliers for non-pandemic volumes and types of PPE. And in the early days of the pandemic, when supply chains were redirected to sectors of greatest need, and this is initially hospitals and subsequently had the inclusion of long-term care homes when tragedy hit there, home care companies could not source adequate PPE. And even those organizations who had guaranteed virtual pandemic stockpiles in place could not secure delivery of that guaranteed stockpile. And I can share with you that at VHA, we could not obtain surgical masks, period. We hit zero inventory very early on in 2020. So what I can share with you is, luckily, post-SARS, our CEO, who says she hates throwing anything away, maybe it's the working in the nonprofit charitable sector, decided to keep our inventory of expired N95s, which we were able to use in place of surgical masks. Of course, we tested the elastomeric straps to ensure that they were functional, which they were. And this carried us through 5 weeks of no access to product until supply chains opened up. So this is just one really great example of being resourceful to meet a really, really important gap. So now I'd like to talk about innovative. And here I'd like to talk about the distribution of PPE, which you can imagine is different in the home care sector. So again, unlike hospitals or institution-based healthcare where PPE can be stored in a dedicated room or on a dedicated cart on a unit, and workers can come to work and directly receive the PPE that they need for that day, home care requires a kind of distributed supply chain. What we have is workers typically attend one of our offices every 2 weeks or once a month to pick up a box of gloves or a couple boxes of gloves, whatever their allotment of PPE typically is, which they then carry around with them in the community. And so what home care was experiencing in the early parts of wave one was significant numbers of staff crowding our offices to pick up greatly increased amounts of PPE. And if this had continued, it would have completely cleaned out our inventory almost right away. In addition to that concern, we all know that having crowds attending offices was the exact opposite of what should be happening during a pandemic. So, our organization had to quickly pivot, and we created and reverse engineered distribution and designed what we fondly call community hub PPE distribution. And this innovation is still in use today, and I imagine will be in use for some time to come. And what it consists of is a small team of dedicated PPE packers that are at the office, a team of awesome volunteer drivers, a group of really dedicated frontline supervisors, and a very simple online PPE form. Weekly PPE kits containing all 4 points of PPE for droplet contact spread precautions, a small bottle of alcohol-based hand sanitizer, a little pack of disinfectant wipes were built. driven by volunteers to convenient community locations like a Walmart parking lot or a community center parking lot, which back then were wide open with lots of space. And they were distributed to staff by their supervisor at within a 1 hour or a 2 hour drop-in window. And we were able to accomplish mass and safe distribution of PPE in this way. And this innovation also had another really important positive outcome. It provided an opportunity for weekly check-ins in person for teams with their supervisor, where they were able to receive information, reassurance, and education. We were able to put treats in kits, little notes from the CEO, communication materials that workers could share with clients and families. And we were able to also put things like resources, so updated screening questions that should be asked at every visit, guidance on how to do great hand hygiene, how to don and doff PPE. And once supply chains were a bit more stable, we were able to move to a 2-week delivery cycle. So that is, I think, a phenomenal example of a pivot, a reverse engineering, and a great innovation that has been sustained. So I'm just going to pause here before I move on to the third area, which is working together. And I'd just like to emphasize the importance of this program. It's probably one of the most important actions we took in setting up these community hub PPE distribution models, as there really is nothing more important to healthcare workers during a pandemic than regular access to their supervisor for information and enough PPE to do their job safely. If you were to try and sort of distill it down to 2 critical elements that have to be in place, in the early days, it was those 2 elements. If an employer during a pandemic wants to show you that they value their employees, this is the way to do it. And I think many of us were witness to really impactful videos on social media of healthcare workers who did not feel that they had adequate PPE to do their job, and how terrified they were to go to work. So I'm happy to report that when we did our incident command team debrief and evaluation of the our Wave 1 response efforts, 95% of nurses and PSWs surveyed indicated that they felt they had enough PPE to work safely. This is so reassuring to me, because I think, there was the incident command team and our senior leadership team who really knew, how we were doing and how difficult it was to source PPE and distribute PPE. So we were so relieved to hear that our frontline teams felt supported. So finally, let's talk about working together. And I think that, as VHA has the bulk of its services in the Greater Toronto area, working together with other Toronto home care service provider organizations was absolutely critical. So a group of 22 home care organizations came together under the Ontario Health Toronto Region Pandemic Planning and Preparedness Structure to respond collaboratively to the crisis. And one of the most important accomplishments of this group was the development of universal masking guidelines for home care. These guidelines were developed by the group based on guidelines that were being developed for hospitals and implemented at the same time that the hospitals implemented their universal masking policies. And I just want to highlight that this was 6 weeks before they were recommended through ministry guidelines. 6 weeks, it's a long time. Implementation of universal masking in home care was the week of March 24th, and the guidelines came out on May 4th. Looking back on that now and fully understanding the benefits of masking, as we've all come so far with this whole notion of universal masking, this early move, I truly believe, has to be one of the key reasons that there was very little evidence of infection transmission from home care workers to their clients. The home care sector group went on to implement recommendations around the use of cloth masks during travel in the community or on the TTC for our workers. And again, we put this into place 6 weeks before the province recommended universal masking in public spaces. And we also implemented universal eye protection recommendations in May, which only emerged in guidelines this fall. So, these early implementations of leading practices in home care, I feel absolutely contributed to the lack of significant evidence of spread of disease in our sector. So I've mentioned a few times the lack of significant evidence of spread of COVID-19 from home care workers to clients. And certainly I want to say that there have been cases. Some have been high profile and in the media. There was one in Kingston recently. But there is no emerging evidence that this transmission is a problem. And even as we've seen holds and cancellations reduced and referrals come back, we have not seen this grow to be a problem. At VHA, we have no evidence of spread of infection from our workers to their clients. And I feel I can say that with some confidence because now that Toronto Public Health has restricted their contact tracing efforts to high-risk settings only, like long-term care homes and schools, because they're completely overwhelmed, we are having to do our own contact tracing. So we notify clients when there is a risk of exposure to a staff who has tested positive for COVID subsequent to a visit. And at our organization, we have one person making these phone calls to clients, and that's me. And I have not had a single case where there's evidence of transmission when talking to these clients. Thankfully, the risk of transmission is low, should be low, because our workers are wearing universal personal protective equipment. They are not symptomatic while they're working. It has happened subsequent to their work. And we do have more and more and more clients wearing masks during visits, which is great. So just a quick note, occupational transmission of COVID is also very low in home care. In our wave 2 response, so since the summer ended, we've only had 4 cases where our worker tested positive, but is unable to identify a community-based exposure that could have resulted in the transmission of infection and was caring for a COVID positive client. Of course, we don't know and we're not sure that these cases were occupational, but there's a chance they could be. So, taking a duly diligent approach, we investigate every single one of these closely, identify actions for improvement and implement those actions immediately. But still very low cases, especially considering the fact that, we know that there's been over 10,000 occupational cases in healthcare workers in the province. I have to share that in the early weeks, even though there is this lack of evidence of transmission in the home care sector, in the early weeks of wave 1, home care workers were tagged by the public and unfortunately by members of the health and medical community as being, and I put this in quotations, vectors of disease. And we had several cases of concern, but at one case that will stay top of mind with me forever is that we had one client's daughter who wanted to spray our nurse down with Lysol before allowing her into the house. And I remember her supervisor forwarding me the email that she sent her, just a very short message with the sort of the description of the wanting to spray down with Lysol, describing sort of what happened, followed by a simple question, which is, what do I do with that? And in debriefing with her afterwards, her question to me was, can you imagine this happening in a hospital? You can't imagine that ever happening in a hospital. And it's important, this is another one of those really important differences between institution-based care and home-based care, is that the home sector, patients in hospitals are visitors. In our sector, it's the other way around. We are the visitors in people's homes. And the bottom line is that, we have to put every effort forward to make sure every healthcare worker in our system is treated with respect and dignity. Thankfully, the narrative has drastically changed, especially with the tragedy of the COVID transmission that occurred in our long-term care sector with such devastating outcomes. Home care truly now is seen as one of the safest places to receive care. And I have to say that, you know, in addition to some of those examples around PPE and supervisor connections, the sector has successfully implemented a staff self-monitoring, daily attestation to fitness to work, client screening on the phone beforehand and again at the door, staff education, training, resources and tools, hand hygiene, physical distancing, and extensive use of PPE, which I mentioned is brand new for the sector, cleaning and disinfection, clearance and return to work policies, and adhering to policies in other sectors where we actually do work, such as surveillance testing requirements for the staff that we have that are providing care in long-term care homes. And recently, I was delighted, absolutely delighted to hear on November 29th that Dr. Samir Sinha, which he was featured on CBC Radio as part of Cross Country Checkup. And he was taking questions from the public on care in long-term care homes during the pandemic. And the last question he was asked was from a home care client's daughter about the safety of care for elderly and fragile clients in their homes by home care workers. And his answer was that while there were concerns in the early days of the pandemic, home care has emerged as an incredibly safe way to provide care. And that's a quote directly from Dr. Sinha. And he noted that in some of his analysis, he found that there's a 77 times greater risk of getting COVID in a long-term care home than receiving care in your own home. So, you know, he called out the sector's great response to the pandemic, but he also called out something really interesting. And he called out that it was because of that very natural pause that happens between visits that allows for things like hand hygiene, you know, tossing out the old PPE and donning fresh PPE to happen. And I'm thinking that in any kind of future talk that I do on this, I might want to call it the pause and think about, you know, what that pause means and how can we use that pause in other sectors to promote safety. It's just an interesting thing to think about, and certainly he triggered that for me. So since the summer, we've seen holds and cancellations decreased, thankfully. They've normalized and stabilized now. Referrals have opened up and are back to normal. Unfortunately, our workforce has not recovered as well. And this is due to some fairly significant factors. One is single employer policies, which are highly valuable policies, but have a significant impact on our workforce. Virtual schooling and lack of childcare spaces, I think, is impacting all of us. And illness is impacting our health human resources. I can say, though, that there have been a couple of things that have been really helpful. One is the temporary pandemic pay. We've seen a couple of examples of that, and the most recent example has been, for the PSW workforce specifically, which is great. And we've also seen short-term disability coverage policies related to COVID open up a little bit, so that we can pay people who are off, having to self-isolate or who are ill. But we are certainly still experiencing a shortage of health human resources, with it being most acute in our personal support worker workforce. So can we move over to slide 5? Thank you. So successes or accomplishments. There's been lots of challenges and lots of barriers, but there's been some great silver linings that I know many of us and many of you will have examples of silver linings to share. I'd like to call out 3. One is virtual care. The second is shift-based care in retirement homes. And the third is the opportunity to help those in crisis. So virtual care has exploded in every sector, and it's exploded in home care as well. It's one of probably the best silver lining across the board. And in the home care sector, early on, late March, early April, there was a change in LHIN policies allowing us to bill for virtual care visits for regulated care providers, so rehab and nursing, which never existed before. So very quickly, we were able to launch a telehealth, so just basically using the phone in rehab, followed by rapid implementation of virtual care by video, using the MS Teams platform. We got off the ground quickly in April, and we were able to have some of our rehab therapists jump on that. Our dietitians and social workers were the first to go. And if you think about the kind of work they do, it was a perfect fit for virtual care. And the other professions followed. We still have the majority of virtual care happening with our the rehab side of the house. And we had a significant uptake, which spiked during wave 1, and now it's settled to be about 10% of visits. So the next area to focus on is nursing. We have rolled out virtual care for nursing. It's great for palliative care education and support and some assessments, but there are limitations to the amount of nursing care that can be done virtually. So right now we're seeing about 1% of nursing visits being virtual. Anticipate, though, that we're going to be seeing some targets come our way in the future, and it'll be exciting to ramp up efforts around virtual care to increase uptake there. So another silver lining for the sector has been the implementation of shift-based care by home care workers in retirement homes. And I explained a little bit about the challenges of the personal support work and sort of some of the factors around its precarity. So with our typical visit model before COVID, we would have had a PSW, during a day, visiting several clients in their homes and several clients potentially in different retirement homes in their area. And of course, we have to make, during a pandemic, the emphasis is on, reducing the number of people who are moving between sites. So in an effort to do this and control the spread of infection, we were able to move to shift-based care models and supported by the LHINs to make that move. This is something that home care employers have wanted to do for many years, as what this provides PSWs is stable and predictable employment and pay and no travel. So, really the ability to recruit and retain PSWs, this would be a factor that would really, really help that. So this is a huge improvement, I think, for the home care sector supporting retirement homes. It's a win-win across the board. And we're really, really hoping that this will continue post-pandemic and spread to all regions across the province. I know that there's concentrated work going on now in the GTA. So I think the final success, or something that the home care sector is really proud of, is the assistance that we were able to provide to long-term care homes in crisis. So during wave, even with our own health human resource shortages, during wave 1, long-term care homes in outbreak had significant staffing shortages. We all read the stories in the media, and homes were putting calls out for assistance. And VHA was one of the many organizations that assisted. And again, I think there was many wonderful stories of organizations that stepped up to support long-term care in a variety of ways. But VHA was able to provide 30 staff permanently deployed to 9 long-term care homes in outbreak or in need. As I mentioned, fully deployed, which is great for our PSWs in particular, because again, ability to have stable and predictable shifts in pay, which is wonderful. And they were also paid for the 2 weeks isolation period that they had to do before returning back to their community work if the home was in outbreak when their term completed. And when I talk to these folks afterwards, what was the experience like? They all volunteered for the work, and they certainly found the work challenging, but they found it incredibly satisfying to be able to help out and to be a skilled group that could offer services and fill a gap and meet a need. And I think that that's absolutely wonderful. And, we're really proud of our ability to support, and we'll be looking to continue to do that. So I'm just going to move us along to slide 6, and I am coming to the end of the presentation here. Great, thank you. So as I mentioned at VHA, I was the lead for the incident command team, still am. And I have to share with you, I've had a long career, lots of great opportunities for leadership. This has been the greatest leadership challenge and opportunity that I've ever had. We launched our incident command team really early, January 24th. We took a bit of a hiatus in the summer, got a little bit of a break, and relaunched again at the beginning of October when we saw our case counts start to exceed what we had experienced in wave one. And we also started to see new issues coming up that required resources and a coordinated org-wide response. So I'd like to share with you some of the learnings that I had. Listen to the scientific experts, use honesty and transparency, and don't be afraid to say, I don't know. Get comfortable making decisions before you have all the information. Move ahead with confidence, but be ready to pivot. And probably most important is look after your people. So I'm just going to start very briefly with the first one. Listen to the scientific experts. Again, one of the silver linings, I think, in this pandemic is that we had Public Health Ontario and the Public Health Agency of Canada, who really did a phenomenal job issuing guidance and updating guidance based on their best evidence and knowledge. And at VHA, I can tell you that, it was our sort of North Star was to follow these guidelines. Sometimes we acted early and implemented leading practices ahead of the guidelines, but once the guidelines were out, we always followed those. It was certainly challenging to navigate some of the media that was presenting conflicting messages, but we were able to sort of stay the course and manage the bumps by following the guidelines. So that certainly got us through. Over communicating is what we all know we need to do in a crisis, but what do you actually say? And I think that what I learned is that you just are honest and transparent, and you should never be afraid to say, I don't know, but I'm doing my best to find out. We lined up some key informants to help us out. Home care is a non-medical sector. We do not have physician leaders in our sectors. We have great practitioners, but we do not have access to IPAC physicians, let's say. And we were able to leverage our Ontario Health Team partnerships, who were so generous with their IPAC experts and instrumental in helping us navigate how to translate hospital-based policies into the home care context. In some of our communications, in all of our communications, we always shared case counts, staff number of cases, number of staff recovered, number of staff back to work, number of client cases by region. We wanted everyone to know and to be able to follow exactly how the health of the organization was and how our clients and families were doing as the pandemic progressed. And of course, as many of you and all of us probably did, multiple channels of communications for clients and staff and lots of opportunities to ask questions. So making decisions before you have all the information, and that's a challenge for us because healthcare is very comfortable with evidence-based decision making and evidence-based practice. It's our cornerstone. But during a crisis, when sort of evidence is being generated as the crisis progresses, it's critical to make the best decision you can before you have all the information. And one of the mottos that our incident command team had was that we are committed to doing the next best thing. And that's what we committed to. We will always do the next best thing. And then once a decision is made and you move ahead with confidence, you have to be ready to pivot if something changes. And oh my gosh, how things changed. In home care, we had 5 versions of the home care guidance, many versions of screening questions to ask as the knowledge of symptomology grew, and many versions of guidance on testing and clearance and managing cases and contacts. And of course, we had to follow sector guidance in other sectors where our staff were working, right? In long-term care homes and their guidance, retirement homes and their guidance, schools and their guidance. So it was a ton of pivoting all the time. And then I'm just going to finish by talking about looking after your people. If there was ever a time to lead with compassion, leading with compassion is always good, but if there was ever a time to lead with compassion, it's now. When our staff call us to tell us that they've tested positive for COVID or they have symptoms and they're going for a test and they can't work, your first question has to be, how are you doing? Do you have family to support you? Is there anything you need from us? Can we arrange for food delivery? And to make sure that you set up a system to check in with them regularly, especially our PSW workforce. Checking in regularly, actively managing their return to work, and always respecting privacy and confidentiality is how we approached sickness and concern about being positive with our workforce. So let's just move on to the very last slide. Thank you. So I think I will leave it there, even though there's so much more I could talk about. I think it's 1:47, so it's the right time to stop. But I will loop back right to where I started and just close by saying thank you to Anne and Nikki and Patty and the group for inviting me. And I truly do hope that participants today, whether you're an educator, an education researcher, a leader, a healthcare worker, or a student and a learner, that this insight into the experience of Ontario's home care system during the pandemic and the emerging evidence that it truly is the safest place to receive care right now will be helpful to you in your ultimate quest to provide safe and high quality patient care. Thank you.
Thank you, Kathy. And I'm going to rely on our technical people in the background. I'm not sure, can you hear me, Catherine?
Yeah.
Perfect. Okay, so the audio is working. I know Michael and Patty are pulling up our Slido questions. So Patty, I think what I'd like to do, it's Anne here, everybody in the background, and I'll facilitate a few questions in the remaining time. First, just want to say, Catherine, extraordinary talk, so much information in a very short time, and so inspiring in terms of just the innovations and resourcefulness that you shared with us. So I think just as you ended your talk with look after your people, I'd like to start with the last comment, Patty, if we could highlight that. And somebody has written, "We are grateful to you all for your selfless service. Thank you for everything each one of you do in the normal times as well as in the stressful pandemic times." And if we could go to the third question, Patty, please, which is, again, an expression of thanks, Catherine, for all the work that you've done in this important sector. You started this talk with a mention about implications for health professions education. What kind of lessons learned would you like to see make their way into health professions education?
Yeah, so I think, if I reflect back on my own personal experience, and I mentioned that, I have a significant amount of time spent in the acute healthcare sector. I knew nothing about the home care sector. And I think that, nowadays, and it's especially important now that we are, our system has such a focus on integrated care and a seamless journey for clients between sectors, that healthcare workers understand where their clients are going and what's different about that sector. What would they need to share with their client as they were transitioning them to another sector? How might things be different? How might things be the same? And even better, if that worker themselves had an opportunity to spend some time learning in that sector, shadowing in that sector, so that they could say, I know you're being transitioned to rehab, or I know you're being transitioned to home care. Don't worry, I've seen what they do. They are fabulous. It might be different and it might take you some time to get used to it, but they're there to provide high quality and safe client care in that context, and you will be fine. I think that is probably the key thing I would like to see health professions education include.
Thank you, Catherine. We'll just move on to the next question, Catherine, which is what resources were provided to the staff for taking care of their own wellness while they were working hard to serve others?
Yeah, great question. So, I think one of the things that our staff really relied on was their supervisors. So I really felt like part of my job was to look after the supervisors. make sure I was, supporting our supervisors so that they could turn around then and do a great job supporting their teams. There was a ton of mental health and wellness supports that came out from a variety of places. Our own benefits and EAP provider is awesome. I was going to say was awesome, but is awesome and has tons of information and sort of education, mindfulness, free mindfulness sessions. I can't tell you how many things there were available through EAP and other free associations and agencies. And I think really that support when people were ill or had to be off, whether they tested positive or tested negative, we had over 300 people who went for a test and it came back negative. But the anxiety of waiting for that test and the inability to work during that time was very stressful. So making sure that we ramped up our HR team to be in constant contact with those staff to make sure they were okay, and that we heard the results so that if we needed to put more supports in place, we could, and if they got a negative result, we would want them to come back to work right away.
Thank you. Thanks. The next question I find very interesting. So of the changes you made in response to the pandemic, which do you think will remain post-pandemic? And I'm really interested to hear, Catherine, about your reflections on teamwork across a competitive sector. What sustainable is that? Your transition to virtual care, how sustainable is that?
Well, so let's start with virtual care. I think virtual care is here to stay. It's here to stay. We're not going to go backwards. We're only going to grow that. Everybody wants it. Everyone's wanted it for more than 10 years. It's been brilliant. I think we need to figure out where is the pendulum going to settle. The pendulum was way the heck off to the side of doing nothing. It swung way over to the other side, and now it's settling somewhere in the middle for different sectors. And I think that we need to see where it's going to settle and go with that. But that is here to stay. And your question about collaboration, especially in our competitive sector, that's here to stay too. Sorry about the dog barking in the background, the joys of working from home. That's here to stay too. I think that, our system is moving towards a whole new model of integrated care through Ontario Health Teams. And the home care sector is in for a massive change because we're looking sort of down the pipes at new legislation and obviously highly likely new funding models. So big changes ahead, and we are absolutely going to have to work together to make sure that Ontario Health Teams are successful and that home care clients still receive great service while we're changing over. So that collaborative effort was ramped up during COVID, and I think it's going to have to stay ramped up.
Mm-hmm. Okay. We have 5 minutes left, Catherine, and 2 remaining questions. We'll try to get through them. So the first one is, given how important we've seen PSWs to be in this sector, do you anticipate any changes in the way the home care workforce is organized, particularly the way PSWs are educated, employed, and or regulated?
Yes. So, we call, I don't know if I mentioned this in my talk, we call PSWs the backbone of home care. They are absolutely the backbone of home care. And if we're going to, really leverage our home care system to hold up our public health system in the province, we are going to have to invest in PSWs. It's a great question. You mentioned education, employment, and regulation. So education, there is a standard curriculum, which is great. It's the delivery piece that makes for a complex landscape. But I can tell you that those organizations that are delivering PSW education are doing a great job, and they're partnering with frontline providers like ourselves to get feedback on what's changing at the front line so that they can change their academic curriculum. So, there's great things being done on the education front, and I think we would just continue to push that forward as the positions are highlighted or being elevated. Employment relationships, I think something needs to change. It is precarious work, low pay, unstable, unpredictable hours, which is no good when you're trying to raise children and, pay for a mortgage. It's something that, it's not ideal to say the least. And I think we've seen some positive moves during COVID. I mentioned the retirement home shift-based model. And I really think that we need to think hard about, not necessarily using more funding, but using funding differently to create buckets of service where there's flexibility within that bucket to provide less or more service based on client need, as opposed to, thou shalt be there for 30 minutes, regardless of need. Even though there is assessment up front, ongoing assessment is difficult to maintain. So I do think that we need work in the area of employment models. Regulation is another great question, and there's been lots of trials around the block with this one. And I think that the notion of regulation, the underpinning driver there is public safety. And I think public safety is absolutely something that we need to consider and look after. Is regulation the way to get better public safety? I'm not 100% convinced on that for the PSW workforce, but certainly I think focusing in on public safety, and the best way to achieve that is where we should focus our efforts. So there's lots of conversation, and Anne and the Michener team is well versed on the conversation around regulation of this important health occupation.
Thank you, Catherine. We do have a question, but we're already at 1:59. So what I'm going to suggest to the person who posed that question, we will post this, we'll send it to you, Catherine, for your response, because it's a question that's dear to your heart, which is education of clients and families, as well as staff. So I think I know you've talked a lot with us about the importance of having education for the 80% of families and friends who are supporting people at home, Yeah. So we will take that one offline. I just want to say once again, Catherine, such a stimulating, wonderful, inspiring talk. And again, I echo the comments on Slido. With just extraordinary thanks to you and to VHA for everything you're doing in the sector.
Thanks, Anne, and thanks for the invitation, and also for the great questions.
Thank you so much. Bye, everyone.